Hi, thank you for joining us. I'm going to be speaking today about the management of a patient exposed to Ebola and other filoviruses. My name is Larissa Pisney. I'm an associate professor of infectious diseases at the University of Colorado, and I'm also the medical director for the metro region of UCHealth. Um, I just wanted to open with this slide. And I think, if anything, the COVID-19 pandemic really taught us this, but this is something that Dr. Fauci said in 2007 when speaking about AIDS fatigue and why Americans should care to CNN. The world is a place that is so interconnected that what happens in another part of the world will impact us. And then I pulled out this graphic from a text or from an article in Nature, where this graphic's really showing that since the 1970s, about 40 infectious diseases have been discovered. And the World Health Organization reports that infectious diseases are emerging at a rate that has not been seen before. Red represents newly emerging diseases, blue are re-emerging or resurging diseases, and then black on this graphic are those that are deliberately emerging. And so you can see here Ebola virus in this like bottom right corner is one of these diseases. There are many factors that contribute to this emergence of new infections. So there are the natural processes of how pathogens evolve over time. So genetic mutation, changes in populations of reservoir hosts or intermediate insect vectors, and microbial switching from animal to human hosts. Obviously, at the time of this recording, we're talking a lot about avian influenza, for example. And then there are also these human behavior and practices that are contributing to this. And so some of these things are population growth, urbanization, destruction of natural habitats, humans and animals living in close proximity, which is certainly very pertinent when we talk about Ebola virus. Viruses, climate change leading to change in ecosystems. We've seen this with the spread of dengue virus, for example, in recent years. International travel and commerce. I think many of us saw the graphic of just like airplane travel and how that contributed to the spread of COVID-19. Additionally, these social factors such as poverty, social inequity, war, and famine all contribute to the spread of infections. And then lack of political will and breakdown of public health measures. And this, relates back to the previous line with natural disasters such as earthquakes and floods. We've certainly seen that in places such as Haiti. And then, of course, with those deliberately emerging infections, the intent to harm. So learning objectives for this talk is to define the classes of filoviruses that cause hemorrhagic fever, but really I'm going to focus on the clinical presentation and treatment of patients with Ebola disease, though it would apply to the entire class. I also am going to summarize the factors that contribute to the transmission of Ebola disease in community and healthcare settings, and then also go over key steps related to the early identification and prevention of cases of Ebola disease in the community and healthcare settings. So filoviruses are a family of viruses that cause hemorrhagic fevers in humans and primates. There are 6 genera. So the most important are Ebola viruses and Marburg virus. There are 4 different ortho-Ebola viruses that cause illness in humans. And of these, the ones listed here, the Ebola or Zaire virus, which causes Ebola disease, the Sudan virus, and the Typhus virus are the ones that we see most frequently. There are also 2 other Ebola viruses, Reston and Bombali, that only have been to date shown to cause illness in non-human primates and pigs. Ortho-Ebola first appeared in 1976 in two simultaneous outbreaks in Africa. So one of these was the Ebola virus in northern Zaire, which is now the Democratic Republic of Congo, and the other was the Sudan virus in South Sudan. Marburg virus was first identified in an outbreak in 1967 in laboratory workers in Marburg and Frankfurt were infected with a previously unknown infectious agent. This is, just that classic electron microscope view of an Ebola virus that is often shown when you're hearing about these cases on the news. And then, for the remainder of this talk, I'm just going to refer to Ebola disease, but really, all of these things can be related back to just viral hemorrhagic fevers in general. But this is a rare but severe and often fatal illness in humans. Ebola viruses often spread at low rates in certain animal populations where Ebola disease is common. So this is things like fruit bats, which there's a picture of here, chimpanzees, gorillas, monkeys, forest antelopes, or porcupines. And then the virus then is transmitted to people via close contact with an infected wild animal in a spillover event. And then human to human spread occurs by direct contact with bodily fluids. And this is usually during the care of an ill family member or during certain funeral rituals. The incubation period that's been described ranges from 2 to 21 days, but classically the onset of illness is abrupt and characterized by what we call dry symptoms of fever, headache, joint and muscle aches, as well as sore throat and weakness about 8 to 10 days after exposure. And then typically about 4 to 5 days later, patients develop what are called wet symptoms. And this is really where we worry about the transmission of illness within humans. So diarrhea, vomiting, stomach pain. Patients can also get rash, red eyes, interestingly, hiccups, internal and external bleeding, as well as seizures. And so with supportive care, the fatality rate is around 50%, but has been described up to 90%. It's really not well understood why some people are able to recover and others do not. And then I didn't want to spend a lot of time on this, but Ebola disease outbreaks by species and size since 1976 are highlighted here in this graphic. The 2014 to 2016 outbreak in West Africa was the largest outbreak, and there were 3 countries that had widespread transmission during this outbreak: Guinea, Liberia, and Sierra Leone. And then there was spread to other parts of Africa as well as Europe and notably the United States, with over 28,000 suspected, probable, and confirmed cases and over 11,000 deaths. So really a significant outbreak. In terms of taking care of a patient with Ebola virus disease, the diagnosis is typically made via PCR of the blood, though ELISA and IgM tests are available. For us in the United States, these can only be ordered with state health and CDC approval. Very important that facilities have protocols for collecting and packaging labs safely if you're evaluating a person under investigation for Ebola disease, and that specimens are not sent to the main laboratory and certainly not ever via the pneumatic tube system. And then, when these patients are being seen, it's very important to take an extensive social history, understanding their travel or contact, and then thinking about their differential diagnosis, which oftentimes includes things like malaria, typhoid fever, influenza, and meningitis. Treatment is really supportive care. So this is rehydration with fluids and electrolytes, as well as symptomatic treatment. So vasopressors to support blood pressure, and medications to treat vomiting, diarrhea, fever, and pain, as well as any secondary infections that develop, because these patients truly are, quite critically ill, and so not uncommonly develop additional infections. There are currently 2 monoclonal antibodies approved for the treatment of Ebola disease, for the Zaire Ebola virus. These were approved by the FDA in 2020. So the first drug approved was Inmazeb, and this targets the glycoprotein that is on the surface of Ebola virus. And in the PALM trial that was conducted during an outbreak in 2018 to 2019 in the DRC, they showed that patients who received this monoclonal antibody had a mortality at 28 days of about 34%, compared to 51% in the control populations. And then the second drug that was approved just a few months later in 2020, Ibanga, blocks binding of the virus to the cell receptor, preventing entry into cells, was also studied in this PALM trial. And the mortality rate for patients who received this drug during the initial trial was 35%, compared to about 50% in the patients who received a control. So as you can see, a significant impact on mortality with these 2 medications. There's also an Ebola vaccine that has been approved called Ervebo in December of 2019. This is a single dose vaccine that's safe and effective, again, against only the Zaire Ebola virus, which has caused the majority of the largest and most deadly Ebola outbreaks to date. And so in the United States, in February of 2020, before ACIP became, inundated with other activities, this was approved as pre-exposure prophylaxis for adults 18 years or older, who have a potential occupational risk of exposure to Zaire Ebola virus. So this includes those responding or planning to respond to an outbreak caused by Ebola virus, lab workers at biosafety level 4 activities or facilities, as these viruses can only be used in those settings, and then healthcare personnel working at federally designated Ebola treatment centers in the United States, of which there are 13. And then within Africa, these are really used during an outbreak to protect persons at high risk of contracting Ebola disease under a ring vaccination strategy. So really part of the process used to end outbreaks after they've started. The vaccine reduces the risk of infection and has been shown to at least half the mortality rate. So when we think about controlling Ebola outbreaks, there are lots of buckets that we need to think about. The first is case management, so how we're caring for that patient and their contacts. Infection prevention and control practices are very important within this. So avoiding contact with blood and body fluids, including urine, feces, saliva, sweat, vomit, breast milk, semen and vaginal fluids, and then avoiding contact with any fomites that could have come in contact with an infected person's blood or bodily fluids. Surveillance and contact tracing is critical. So patients or individuals who have had close contact with a person with Ebola virus are put on a 21-day symptom watch, and so are asked to check their symptoms several times a day, as well as their temperature, and ideally have a public health contact that they can notify at the first sign of symptoms. So that person could be screened in an appropriate medical facility and tested, treated if appropriate. Good laboratory services. Certainly having a delay in testing can lead to further spread of infection in places where Ebola virus is common. Safe and dignified burial. Funeral and burial practices that often involve touching the body of someone who has suspected and confirmed Ebola are well known to contribute to the spread of this illness. And then social mobilization. So really how we're in areas where Ebola virus is common, how we're educating the population and meeting them where they're at. So educating around things about avoiding contact with those animals that I mentioned earlier, as well as the meat of these animals, particularly if it's raw. And then, things even such as a man who's recovered from Ebola virus disease, that person should not have unprotected sex until they've been shown to no longer be able to spread the virus via their semen. And then, if appropriate, if it's that Zaire Ebola virus, vaccination is a very important measure within outbreak control. Within the United States, as we think about Ebola, and I think this ties back to that first statement that I brought up, so what happens in other parts of the world does impact us. There are three, main steps that we really try to hammer home. So identify, isolate, and inform. When we do know that there's an Ebola virus or Ebola disease outbreak happening, it's very important to have triage processes in place for appropriate screening. Identifying patients that have the correct international travel or known contact with someone with Ebola virus and that have symptoms consistent with illness. Isolating those individuals immediately when they're being seen in a healthcare setting. So separating them from other patients, putting them in a private room, wearing appropriate PPE, and then limiting and tracking the healthcare personnel who have contact with that patient. And then lastly, inform. So this is really notifying infection control, your special pathogens team within your facility, and then local public health, state public health, and then which would certainly pull in the CDC if it was truly a person under investigation, so that contract tracing can occur, appropriate testing can occur. All of those steps to prevent further spread of illness is very important. I do think it's important when we think about international travel, and we certainly experienced this here during the 2014 to 2016 outbreak. It is important to provide education around where the outbreak is and what that means geographically. We certainly had many false alarms related to travel to Africa, but as you can see from this graphic, there are 15 countries that you could essentially smush into the land size of Africa. Number one, the gray swath is the United States. So when we say West Africa, or those three countries in particular that were having an outbreak at that time, that's a very, very small part of Africa. And so it's really important to get that detailed travel history, or pull in your infection control or infectious diseases team to help you get that travel history. I will say, and this will all, tie back to, those first slides in terms of things that should be done to control a case. And so during the 2014 portion of the outbreak in Sierra Leone, the estimated Ebola incidence was 103-fold higher in healthcare workers than the general population, though there were some lower estimates from different studies that range from 21 to 47-fold increase. But either way, there was certainly a much higher risk of healthcare workers developing Ebola during this time period. And there were many things that fed into this. So lack of standard operating procedures, people coming up with processes on the fly, staff shortages and lack of infection prevention specialists, limited availability for safe transport vehicles for both patients and corpses, incorrect triage or recognizing patients or those who had passed as having Ebola. As I mentioned earlier, delayed laboratory diagnosis of Ebola cases due to long turnaround time, either from specimen transport or getting those results back, led to additional spread. Inadequate control of Ebola patients or healthcare worker movement within health facilities, and then also delineating high risk and low risk Ebola zones. So where you have potential patients with dry symptoms or less convincing exposures versus those with wet symptoms. How we separate and care for those patients is very important. Limited availability of PPE and hand washing, lack of training around how to do those things appropriately. Again, lack of equipment and materials, training related to the cleaning of these spaces, as well as the management of contaminated waste, and also the safe management and burial of those who had passed from Ebola disease were all contributed to spread. This is similar, but more of a visual representation of this. This is a systematic review from JIT that looked at outbreaks of Ebola in Marburg, or cases of Ebola in Marburg, and healthcare workers reported in the literature prior to 2017. And so what you can see here is that there are themes in terms of where risk is introduced. So, very high PPE was either insufficient or inappropriately used. Patients were unrecognized as being infected, incorrect screening. So again, they weren't triaged appropriately. Absent or inadequate isolation areas, and then just overall staff shortages, and in particular lack of infection prevention specialists to help manage all of these elements. And then what I wanted to do was tie into how some of these themes from West Africa relate to cases of Ebola disease within healthcare workers in the United States. This is a timeline of Ebola patients 1, 2, and 3 in Dallas, Texas in late 2014. And so this timeline, what you can see here is on September 25th, a man who's 45 years old arrived in the United States after being in Liberia 5 days earlier. He went to an emergency department with some non-specific symptoms and a fever, and he was treated for possible sinusitis and discharged. He then returned on the 28th as he was moving from dry to wet symptoms. And he, at this time, he definitely had continued fever, diarrhea, and progressed to having vomiting. He was placed in a private room under droplet and contact precautions and was ultimately tested for Ebola, which returned positive on September 30th. Contact tracing identified 48 close unprotected contacts. 17 of these were in the community. 10 had transported this patient in the ambulance or had been transported in the ambulance before it was adequately cleaned and disinfected. And then 21 were healthcare workers with potential exposures to body fluid without appropriate PPE. And then what happened was on October 11th, a nurse who was involved in direct care of this patient developed fever, sore throat, and she was confirmed to have Ebola later that day. And then later on October 14th, a second nurse who had a similar exposure had a fever and a rash. and was also confirmed to have Ebola by PCR. Before her diagnosis, though she was known to have had this exposure, she was allowed to go home to Ohio, and so had traveled October 10th through the 13th. So there was, significant amount of contact tracing that occurred as a result of that. And then when you look at the literature related to this cluster of patients, there are themes that, again, are very similar to what was seen in Sierra Leone, just on a different level. So the response felt chaotic to the nurses. Patient was not initially triaged appropriately, so was not isolated and left in an area with up to 7 other patients. Lab samples were sent through the pneumatic tube system and not labeled as being from a patient with potential Ebola. There were no protocols or training, which then the nurses described using Google search to answer their questions. So not having those standard operating procedures led to coming up with some of this on the fly. They also had concerns about the adequacy of the PPE that was available. And then those nurses who, instead of limiting the number of healthcare workers taking care of that patient, and then who that nurse was taking care of. One of the nurses described having to take care of other patients while taking care of the Ebola suspect on the same shift. So lots of lessons learned there. And so, most public health departments do have some version of this, and this is just from the Colorado Department of Public Health, but this is one of their many available resources for frontline hospital preparation. You can see here that they really hammer home planning ahead and establishing your identify, isolate, and inform strategy, designating areas to care for these patients, going through donning and doffing of your PPE, where that's going to happen, what PPE you're going to use, your steps that you're going to follow, and having trained observers. And also thinking about that laboratory risk assessment and how you will be doing that. And then very importantly, dedicating space and equipment. And then lastly, step 3, which is train and review. And then that one, I would just say rinse and repeat. And so the key takeaways, that I have in looking at all of these are it's very important for facilities to develop triage protocols. So isolating that patient right away in a closed doored room with a private restroom, ideally with a window or a glass door so that activities can be observed. So you have a spotter that can let that healthcare worker and the team know if they're at risk of contaminating themselves. Designating that care location, ideally in a place where traffic can be restricted, having designated care teams identified that are comfortable providing this care and that have been trained on PPE that will be used during the care of a person under investigation. It's very important to think about or to make sure that you're training with the PPE that you will use in a real life situation so people can develop that level of comfort. Having designated areas for donning and doffing of PPE with a clear separation between clean and contaminated areas. And making sure to train observers that can monitor, like I said, monitoring the patient care at all times, monitoring donning and doffing. Oftentimes these are people who can also assist in just-in-time training. Which is, potentially, depending on the type of facility, will be possible, but having a core group that holds regular training sessions is really important. Having a plan for monitoring healthcare worker contacts, and then developing protocols for things such as laboratory, safe transport within the hospital, and how you're going to manage the environment, clean the environment, as well as infectious waste. And then lastly, I just wanted to go over the most recent outbreak, which occurred in September of 2022 in Uganda. And this outbreak was there were several things that contributed to the ongoing spread in this particular outbreak. The first was that the event started 3 weeks before the identification of the index patient, and several transmission chains and contacts were not traced. Patients presented at various facilities that had suboptimal infection control practices, including all those things we just went over, but inadequate PPE. There were also traditional burial ceremonies that happened. And although the country had developed an increased capacity to respond to Ebola outbreaks over recent years, it wasn't easily mobilized because there were other factors contributing. So there was simultaneous responses to anthrax, COVID-19, Rift Valley fever, yellow fever, as well as some flooding and prevailing food insecurity. So again, tying back to that, how do these emerging infections such as Ebola, how do they, what factors contribute to outbreaks and these being able to happen? And this really highlights, multiple emergencies happening at once. The other thing that was unique about this outbreak is that it was detected in individuals living around an active gold mine. And so these were a lot of people who were not necessarily of the area. And so tried to leave and may not have realized that they were already incubating the illness. This was declared over in January of 2023 with 164 cases reported, with a case, a percentage of fatal cases was 34%. And then, while I talked about the monoclonal antibody and vaccine, this particular outbreak was of the Sudan Ebola virus, so no vaccines or therapeutics have been approved for the prevention or treatment of this particular strain at this time. And so with that, I'd like to close and thank you for your time and attention to this talk.